Before we proceed with the abnormality, let's talk about a few anatomical points. The neck anatomy is complicated by many details. We're not going to go over all the anatomy, but we're going to highlight a few important things. The abnormality is clear on the left side, so let's concentrate on the right to discuss the normal appearance. As we go from above below, we're going to notice a few important cartilages. The first cartilage is this here. This is called the hyoid bone, which has this classic articular appearance on each side. How the cartilage is dense from ossification, which makes it easier to identify in adults. As we proceed lower down, another cartilage that has an inverted V appearance is noted. This cartilage is the thyroid cartilage, and at almost the same level or slightly lower in relationship to the thyroid cartilage, you see this rounded or semi-rounded structure. This is the cricoid cartilage. So from above below you have the hyoid, the thyroid, and cricoid, HTC. Another important piece of information is about these muscles, which are closely related to the thyroid cartilage. These muscles are called the strap muscles. Now to complete the picture, this is the thyroid gland. We go to the level of the oral cavity. This is the base of the tongue, and as we go lower down, you'll see this, which is the epiglottis. This is only part of the anatomy that you could identify in the neck region. However, this is sufficient to understand the pathology we're talking about today. The hyoid bone is a very important landmark, and spaces in the neck are divided into those above, which is the suprahyoid, or those below, infrahyoid spaces. There is this hypodense lesion that has a thin rim without components of enhancement, in keeping with the cystic abnormality. The abnormality is at the level of the hyoid bone and extends below in close relationship to the thyroid cartilage as well. If you compare the normal right side to the abnormal left side, you'll notice that this abnormality is actually embedded within the strap muscles. This overall description is consistent with the diagnosis of a thyroglossal duct cyst. The thyroglossal duct remnant is an embryological structure that extends from the base of the tongue all the way down to the thyroid gland. Congenital cysts may occur in the thyroglossal duct remnant, and that's why the location is midline all the way from the base of the tongue down to the bed of the thyroid. Although most of these thyroglossal cysts are in the center, the midline, they may have a slight off-midline location to the right or to the left. The infrahyoid thyroglossal duct cysts in particular could have a paramidline location. This cyst could be complicated by infection, and in such cases you look for thick enhancement of the capsule and surrounding inflammatory changes. This abnormality may also contain internal thyroid tissue, which could in very rare occasions transform into thyroid cancer. So check the thyroglossal cyst very carefully for abnormal nodular enhancement to rule out ectopic thyroid tissue or carcinoma. For a more complete description for the senior residents, you could talk about the displacement of the adjacent submandibular gland. You could also mention that this lesion minimally pushes into the left paraglottic fat space. You may also mention the relationship to this line here, which you see on the other side. This is the platysma muscle. This was a good case with a bit of information for both the seniors and juniors. First, we recognize that the neck anatomy is a bit complex, but to simplify it, start by knowing the important cartilage. Above below you have HTC, which is hyoid, thyroid, cricoid. The hyoid bone that has these articulations is an important landmark to divide the neck into supra versus infrahyoid spaces. We also learned about the strap muscles, and a classic lesion that is embedded within the strap muscle is the thyroglossal duct cyst, which is classically midline but could be off midline. Once you see such an abnormality, make sure you don't have internal soft tissue or enhancing components for the possibility of ectopic thyroid or thyroid cancer. Finally, thanks for watching. Your comments are well appreciated. See you later. You have seen the frontal chest radiograph, but our teaching point today is about the lateral chest radiograph. Whether it's the frontal or lateral chest radiograph, you probably noticed cardiac enlargement. However, have you noticed something else? Before I explain the abnormality, let's look at a CT scan on a normal patient. So now we're looking at a heart on a CT scan without IV contrast administration. Notice this line that surrounds the heart. This is the thin normal pericardium. The fat outside the pericardium here is called pericardial fat. The fat inside the pericardium between the pericardium and heart here is called epicardial fat. On a CT scan, fat looks the same anywhere in the body. So compare the fat in the subcutaneous tissue with that in the pericardial epicardial areas. Now let's look at an abnormal CT scan of a patient who has this here, where the pericardium appears thicker than the normal case. The pericardium appears thick on this case because of the presence of fluid known as pericardial effusion. Now the pericardial fluid is surrounded by the pericardial fat outside and the epicardial fat inside. Now let's look at the lateral chest radiograph again, where I will give you the chance to translate what we saw on the CT scan on this image. Looking carefully at the lateral chest radiograph, you will notice that there is an area of lucency here and another similar area of faint lucency here. Go over these two lucencies again, this here and that there, and these lucencies are consistent with fat on a chest radiograph. This is the outer pericardial fat and this is the inner epicardial fat surrounding thickened pericardium. We know on chest radiographs that the density of fluid is similar to soft tissue and higher than fat. So this is a case of pericardial effusion. This sign of pericardial effusion on a lateral chest radiograph is known as the Oreo cookie sign, since the appearance resembles an Oreo cookie. So we learned from this case that cardiac enlargement may be due to pericardial effusion rather than chamber dilatation or hypertrophy. We also learned that there is the pericardium that is thin, surrounded by outer pericardial and inner epicardial fat. We learned that fat is of low density on a CT scan and of a relatively lower density than soft tissue on chest radiographs as well. Knowing these facts, the pericardial and epicardial fat surrounding a dense fluid within the pericardium is a sign of pericardial effusion. The sign is famous for being called the Oreo cookie sign. Thank you for watching. Your comments are always appreciated. See you with more cases. This is a pediatric neuroimaging case. It's kind of a show and tell of multiple abnormalities directed for seniors. However, the case is interesting and I'm sure the junior followers would get something out of it as well. One of the major abnormalities is dilatation of the posterior fossa by a cystic structure. This structure leads to elevation of the confluence of the venous sinuses and elevation of the posterior aspect of the brain. The brainstem itself is distorted and hypoplastic. The posterior fossa cystic abnormality communicates with the fourth ventricle, and the central aspect of the cerebellum is hypoplastic. This central aspect is called the cerebellar vermis, which is a structure that you should see in normal cases. The constellation of a cystic structure dilating the posterior fossa and elevating the structures communicating with the fourth ventricle and cerebellar hypoplasia is consistent with what we call a Dandy-Walker malformation. Now, the golden rule is if you see one congenital abnormality, look for the other. And here's another one. There is a calvarial defect through which the meninges extend outside of the brain. Such extrinsic protrusion of the meninges is called a meningocele. As we said, if you see congenital abnormalities, look for others, and there are others in the rest of the brain. There is distortion and dilatation of the ventricular system. Normally, you should see communication between the left and right brain by what we call the corpus callosum, which is absent here. So this other abnormality is called corpus callosum agenesis. Now, the case did not finish yet, since you also have other abnormalities. If you look at the gray matter, it looks totally distorted. First of all, the cortex looks extremely thick and there is increased undulation or gyration. This type of cortical dysplasia is known as polymicrogyria. One of the known congenital abnormalities is also abnormal migration of the gray matter. Such abnormal migration of the gray matter with resulting deposits within abnormal locations within the white matter is called heterotopia. There are different forms of heterotopia. One form we see here is this nodular appearance around the ventricles, what we call nodular heterotopia. Another form might look linear surrounding the ventricles, simulating a band, and thus the name band heterotopia. So this was a neat show and tell case of Dandy-Walker malformation, meningocele, corpus callosum agenesis, polymicrogyria, and nodular as well as band heterotopia. A bit of a tough case, but an interesting and educational one. Thanks for watching. See you with other cases. There is a large, low-density, well-defined lesion within the right liver lobe. The abnormality has no perceptible wall and does not lead to adjacent inflammatory hepatic changes. In a prior case, we discussed several features of different cystic hepatic lesions. This is one that we did not see before. The distinguishing feature about this abnormality is the presence of this thin undulating internal membrane. The appearance is characteristic of hepatic hydatid disease. Since there are internal hydatid membranes, when they separate, they may float within the hydatid fluid. Sometimes this membrane is not clear on CT scan and is better appreciated on an MRI. This was a quick classic case. More cases later. Thanks. As usual, this is a case that has several teaching points for both the junior and senior residents, as well as students and interns. This patient is known to have a relatively small posterior fossa with a low-lying tonsil in an appearance that is known as Chiari malformation. The patient also has artifacts here from posterior fossa surgery, as well as artifacts related to this structure, which is a ventriculoperitoneal shunt. Despite the presence of these abnormalities, I'm showing this case for another reason. There's this funny CSF space appearance posteriorly that is not consistent with what we see on normal MRI brain. And here's the CSF space on T1. Remember that fluid on T1 is black. You see it here on the sagittal image. To explain why you see this abnormality, you have to concentrate on this structure. The structure here is abnormal, so now we're going to go to a normal case to explain more. This is a sagittal T1 on a normal patient for us to understand the normal anatomy before proceeding with the other case. This curving structure here is called the corpus callosum, which is white matter tract connecting both cerebral hemispheres. And this is a coronal T2 on the same patient, showing the corpus callosum connecting the right and left brain. Now that you know what a corpus callosum is, let's talk more about the anatomical segments of this structure. This part here that is tapered and looks like a beak is called the rostrum. This part that looks like a knee is called genu, and genu is knee in Latin. The largest curving part of the corpus callosum is called the body. And finally, the posterior bulging part here is called the splenium. So you have the rostrum, genu, body, and splenium of the corpus callosum. Several abnormalities may involve the corpus callosum, and they could be acquired or congenital. One of the congenital abnormalities would be agenesis. To better understand agenesis of the corpus callosum, we need to know how the corpus callosum develops in a fetus. The first thing that develops in utero in the corpus callosum is the genu, followed posteriorly by the body, then the splenium. The last portion to develop in utero is actually the rostrum. So the corpus callosum develops from anterior to posterior, genu, body, and splenium, apart from the rostrum that is the last thing to develop. You may have partial or complete agenesis of the corpus callosum. In cases of intrauterine partial agenesis of the corpus callosum, you should not see the rostrum, meaning that you could see a genu on part of the body with absence of the posterior components and absence of the rostrum. If the rostrum is present and there is any abnormality in the corpus callosum, that means that the abnormality occurred after total development. So with partial agenesis of the corpus callosum, you'll have absence of variable degrees of these components in addition to absence of the rostrum. Now let's go back to our abnormal case. You probably have figured out that there is partial agenesis of the corpus callosum. The splenium is absent and the posterior part is thin. Of interest, although the genu and part of the body has developed well, the rostrum is absent as expected. Now that you better understand the corpus callosum, notice that the anterior part is connecting the brain here, where there is no connection posteriorly, consistent with the sagittal image. And that's why the CSF spaces posteriorly look funny, and many people would look at this and confuse this for a cystic abnormality, which is not the case. So to summarize, this is a case of a Chiari malformation with partial agenesis of the corpus callosum. Our first teaching point is to understand that the corpus callosum connects both brains. Our second teaching point is to know that it is composed of the rostrum, genu, body, and splenium. Our third point is to understand that it develops from anterior to posterior except the rostrum, which develops last. Finally, the rostrum should be absent in cases where you have partial primary agenesis of the corpus callosum. In cases where you see a rostrum, the insult have occurred after full development of the corpus callosum. This is enough for juniors to understand. However, for seniors, my question is, what is the exception for the rostrum rule that we just mentioned? Thanks for watching today's clip. See you with more cases later.